Action on disease prevention and control will leave many of the most vulnerable groups without better health prospects unless the root causes of ill health are also tackled. All countries, rich and poor, face challenges, and no single mix of policy options will work well in every setting. Any effective strategy for addressing the broader social determinants of health must be locally planned and developed. The health sector has an important role in addressing these root causes, not only in its own services but also by advocating for change and through intersectoral action. Major health benefits can accrue from changes in the social environment. However, incorrect policy decisions may be made if the health effects have not been considered. The health implications of policy decisions need to be taken into account in order to maximize opportunities for health benefits and to avoid the adverse consequences of government.
More recently, the World Health Report 2010, on health systems financing, the path to universal coverage, maps out options for countries to modify their health financing systems so they can move more quickly towards universal coverage, so that all people have access to the health services they need, prevention, promotion, treatment or rehabilitation, without the risk of financial hardship associated with accessing services.
Policies for minimizing inequity. There is evidence that health systems which successfully address equity tend to share several broad features. These health systems aim at universal coverage and offer particular benefits to children, socially disadvantaged and marginalized groups, and others who are often not adequately covered. Integrate social determinants approaches and consideration of health equity into public health programs. Measure inequities in health and monitor actions to address them. Include organizational arrangements and practices that involve population groups and civil society organizations, particularly those working with socially disadvantaged and marginalized group. Decision-making possess leadership, processes and mechanisms that encourage intersectoral action across government departments to promote population health and that cooperate to meet the expectations of these other sectors as well. Receptacles are universal access to contraception, 2015. Strengthening and updating social security to protect our nation's health, 2013. Strengthening health systems in developing countries, 2009. Support for social determinants of behavioral health and pathways for integrated and to better public health, 2014. Support for paid sick leave and family leave policies, 2013. Supporting public health's role in addressing unmet needs in serious illness and at the end of life, 2013. Support for community health workers to increase health access and to reduce health inequities, 2009. Reducing racial, ethnic and socioeconomic disparities in preterm and low birth weight births, 2006. Research and intervention on racism as a fundamental cause of ethnic disparities in health, 2001. Improving housing for farm workers in the United States is a public health imperative, 15, 2011. Reforming primary health care, support for healthcare home model, 2010. Public health's critical role in health reform in the United States, 2009. Ensuring the achievement of Millennial Development Goals, strengthening efforts to reduce global poverty and promote public health, 2009. Support for WIC and child nutrition programs, 2003. A health equity assessment tool for tackling inequalities in health. Recently, the Health Equity Assessment Tool, HEAT, has also been introduced in New Zealand. It is used to review how particular inequalities in health come about and identify how they may best be tackled. A set of questions that can be applied to specific areas to be addressed. What health issue is the policy program trying to address? What inequalities exist in this health area? Who is most advantaged and how? How did the inequality occur? What are the mechanisms by which this inequality was created, is maintained or increased? What are the determinants of this inequality? How will you address the Treaty of Waitangi, the founding document of New Zealand, in the context of the New Zealand Public Health and Disability Act 2000? How will you intervene to tackle this issue? How could this intervention affect health inequalities? Who will benefit most? What might the unintended consequences be? How will you know if inequalities have been reduced, eliminated?
For breaking the cycle of health inequalities, the following actions are to be taken. Reducing poverty through measures in the tax and benefit system. Improving educational attainment among disadvantaged children. Reducing teenage pregnancy and improve antenatal, maternal and child health services for disadvantaged and minority ethnic groups. Promoting healthy schools, particularly in disadvantaged areas. Tackling the major killers, promoting smoking cessation, improving screening. Improving nutrition, increasing physical activity, and reducing accidents, particularly among disadvantaged groups, are identified as key areas for action.
For improving access to public services and facilities. Policies should include to ensure that services are accessible to all, taking into account cultural and language barriers, improving primary care services in underserved inner city or rural areas, improving access to affordable food, and improving accessibility of disadvantaged groups to core facilities. Strengthening disadvantaged communities. Neighborhood renewal of deprived areas, including action on work and enterprise, crime, education, health and housing, promoting environments where people feel safe to go out, and improving housing conditions are included as areas for action to be improved. Supporting targeted interventions for specific groups might be better include ensuring that services can meet the complex needs of vulnerable people such as minority ethnic groups, older people, homeless people, prisoners, refugees and asylum seekers and people with long-term medical or mental health problems. In order to achieve the targets set, action would be required across government. First-line treatment for the poor and having language barrier is alternative treatment. So, an equity perspective in developing country healthcare systems would ensure access to affordable, high-quality services for those. The newly published, May 16, 2002, WHO Traditional Medicines Strategy 2002-2005 focuses on 4 areas that will require action if the potential role of TCAM in public health is to be maximized. These areas are policy, safety, efficacy, and quality, access, and rational use. Within each of these areas, WHO identifies challenges for action. Access. Lack of data measuring access levels and affordability. Lack of official recognition of role of TCAM providers. Need to identify safe and effective practices. Lack of cooperation between TCAM providers and allopathic practitioners. Unsustainable use of medicinal plant resources. Rational use. Lack of training for TCAM providers. Lack of TCAM training for allopathic practitioners. Lack of communication between TCAM and allopathic practitioners and between allopathic practitioners and consumers. Lack of information for the public on rational use of TCAM. These are tasks that have been repeatedly identified by numerous groups. If WHO can now stimulate action by bringing attention, and perhaps funding, to some of these goals, that would be a significant step forward.
Challenges of action for national policy and regulation are: lack of official recognition of T-CAM and T-CAM providers, lack of regulatory and legal mechanisms, T-CAM not integrated into national health care systems, equitable distribution of benefits in indigenous trademark knowledge and products, inadequate allocation of resources for T-CAM development and capacity building, safety, efficacy, and quality, inadequate evidence base for T-CAM therapies and products, lack of international and national standards for ensuring safety, efficacy, and quality control, lack of adequate regulation of herbal medicines, lack of registration of T-CAM providers, inadequate support of research, lack of research methodology.
Thank you for watching the video. Have a nice day.